Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 2 of 3 on red or painful eye disorders in this chapter. In this set of slides, we will discuss 5 etiologies, namely conjunctivitis, allergic conjunctivitis, keratoconjunctivitis sicca, keratitis, and herpes simplex. Conjunctivitis is the most common cause of red or irritated eye. Pain is minimal, and visual acuity is reduced only slightly. It causes a watery discharge, a mild foreign body sensation, and photophobia. The most common viral etiology is adenovirus infection. Bacterial infection tends to produce a more mucopurulent exudate. Mild cases of infectious conjunctivitis are usually treated empirically with broad-spectrum topical ocular antibiotics. To prevent contagion, patients should wash their hands frequently, should not touch their eyes, and avoid direct contact with others. Allergic conjunctivitis is extremely common and is often mistaken for infectious conjunctivitis. Itching, redness, and epiphora are typical. The palpebral conjunctiva may become hypertrophic with giant excrescences called cobblestone papillae. Atopic conjunctivitis occurs in subjects with atopic dermatitis or asthma. Symptoms can be alleviated with cold compresses, topical vasoconstrictors, antihistamines, mast cell stabilizers, and topical NSAIDs. Topical glucocorticoid solutions provide dramatic relief of immune-mediated forms of conjunctivitis, but their long-term use is ill-advised because of complications of glaucoma, cataract, and secondary infection. Keratoconjunctivitis sicca is also known as dry eye. It produces a burning foreign body sensation, injection, and photophobia. In these cases, tear production is decreased. A variety of drugs such as antihistamines, anticholinergics, and psychotropics may result in dry eye by reducing lacrimal secretion. Systemic disorders that may cause dry eye by involving the lacrimal gland directly are sarcoidosis and Sjogren's syndrome. Problems of ocular drying are also common after radiation therapy that includes the orbits, with lesions affecting cranial nerves 5 and 7, and the use of corneal anesthesia. Dry eye is managed by frequent and liberal application of artificial tears and ocular lubricants. In severe cases, the tear puncta can be plugged or cauterized to reduce lacrimal flow. Keratitis is a threat to vision because of the risk of corneal clouding, scarring, and perforation. Worldwide, the 2 leading causes of blindness from keratitis are trachoma from chlamydial infection and vitamin A deficiency related to malnutrition. In the United States, contact lenses play a major role in corneal infection and ulceration. In evaluating the cornea, it is important to differentiate between a superficial infection and a deeper, more ulcerative process. A deeper, more ulcerative process will produce greater visual loss, pain, photophobia, redness, and discharge. Slit lamp examination shows disruption of the corneal epithelium, a cloudy infiltrate or abscess in the stroma, and an inflammatory cellular reaction in the anterior chamber. In severe cases, pus settles at the bottom of the anterior chamber, giving rise to hypopyon. Empiric antibiotic therapy should be initiated immediately after corneal scrapings are obtained for gram stains, GEMSA stain, and cultures. The herpes viruses are a major cause of blindness from keratitis. Primary ocular infection is generally caused by herpes simplex type 1 rather than type 2. It manifests as a unilateral follicular blepharoconjunctivitis that is easily confused with adenoviral conjunctivitis unless telltale vesicles are present on the eyelids or conjunctiva. A dendritic pattern of corneal epithelial ulceration revealed by fluorescein staining is pathognomonic for herpes infection, but is only seen in a minority of primary infections. Involvement of the corneal stroma produces edema, vascularization, and iridocyclitis. Herpes keratitis is treated with cyclopegia and either a topical antiviral or an oral antiviral agent. Topical glucocorticoids are effective in mitigating corneal scarring, but are generally reserved for cases involving stromal damage because of the danger of corneal melting and perforation. Topical glucocorticoids also carry the risk of prolonging infection and inducing glaucoma. This ends part 2 of the slide set for red or painful eye disorders. Next set of slides will be part 3 of red or painful eye disorders, where an additional 6 disorders will be discussed.